What are the types of cell inside our respiratory zone? So it is a type 1 cell, type 2 cells, and macrophages. Type 1 cells are thin epithelial cell. It line about 90% of the surface area of the alveoli. Gases diffuse across the type 1 cell. So this type 1 cell will help in diffusion of the cell, of the gases, sorry. The type 2 cells they are interspersed in between the type 1, and what is the main function of this? They will generate the surfactant. They will synthesize, secrete, and metabolize the surfactant. And alveolar macrophages, they are moving cells. They engulf the inspired articles as a bacteria, virus. These cells are mobile and they are attracted to the areas of either infection or trauma. So they are movable, they go there. What are the vessels? As we know, from the right atrium, pulmonary artery will come, it will branch, it will make a capillary, they will combine, and it will make 4 pulmonary veins. So initially, all in the tree, the artery, vein, and bronchi, they are all together. But as we go to the periphery, the artery and bronchi will still remain in the center, but the vein is into the lobule in between. So there is a dense capillary network inside the in the wall of the alveoli. This is the wall of an alveoli. So they are divided capillaries there. And as we know, the diameter of the capillary is 10 micrometer, and thickness, as I discussed, it is 0.2 to 0.3 mm. Now we think that there is a whole cardiac output. It is going into the right ventricle, and from that into the pulmonary artery. And now there is a very minute arteries and capillary network is there. So there might be a very much pulmonary resistance is there. But it is not such, because there is so much of branching, the resistance divides. So there is a very low resistance into the pulmonary circulation. Now each RBC which is going inside the pulmonary circulation in adult with a heart rate of 60 to 70, it will spend 0.75 seconds into the capillary network and it will come out. And during it travel, it will traverse 2 to 3 alveoli. And this 0.75 seconds, it is adequate for a gas exchange, which we later on discuss. There is additional circulation also, because as the lung is organ, it will also require not the blood only for the gas action. It will require blood for the nutrition and to removal of the other things. So bronchial and Thibetian vessels, they are additional circulation. These blood vessels, they will not take part into the gas exchange. So this is a normal anatomical shunting. This is just for the nutrition supply to the lung and the respiratory tree. So this is a normal shunting of the blood. Oxygen cascade. Now how the respiratory system works, it will take the oxygen from the air and it will provide it to the tissue, the mitochondria. So that full supply of oxygen from air to the tissue, it is called oxygen cascade. As we know, there is a 150 mmHg of partial pressure of oxygen into the air. And when it reaches to the tissue, only about 20 mm of HgPO2 is remain. So this travel of oxygen up to the tissue, that is in uptake in the lung, diffusion from alveoli to the capillary, attachment to the hemoglobin, then regional distribution, diffusion from the capillary to cell, and then the cellular use of the oxygen. It is also full cascade. It is called oxygen cascade. This from uptake of the lung to the diffusion to the cell, it is called external respiration. And when this O2 is being utilized into the tissue, that is called internal respiration. Okay. So today only we are going to look after only this first thing, how the air come into the alveoli. What are the mechanics and what are the property of the lung which will work to take the air from the atmosphere to the alveoli. So we will go only into the first step. So it is called ventilation. How the gas gets to the alveoli. It is a process of inspiration and expiration both. So inspiration, a common known thing, as the diaphragm and intercostal muscle of the chest will contract in response to the neural impulse from the brainstem. So diaphragm descends and intercostal muscle raise the rib. So the chest cavity expand. And because the lungs are functionally connected to the chest wall by the pleural sac, the lung also expand. This will decrease the pressure inside the alveolar duct and alveoli. So there is a pressure gradient. When the pressure in the alveoli, PA, becomes less than the pressure in the mouth, so there is a flow of the air. This is a simple thing. There is a zero at the end of the expiration when there is no air movement. So at that time, there is no difference from the pressure of alveoli and the mouth. So there is both are 0, 0. So no air flowing. Now when the inspiration starts, the diaphragm descends, thorax expands, so alveoli expands. So there is a negative pressure gradient and the air will come into the alveoli. But expiration is a passive thing. All the muscle of inspiration relaxes, diaphragm and intercostal muscle. So due to the elastic recoil of all the respiratory system, they will come into the pre-inspiratory state. So there is a positive gradient of pressure. So all thing contracts and there is a positive pressure in the alveolus and the air will flow out. So it is called a respiratory cycle. Normally in pediatric, the rate is 20 to 40. Both the rate and depth of the respiration will be decided by the brainstem. According to the condition in the body, the metabolic condition, the CNS condition, the brainstem will decide what is the depth and the rate should be. So accordingly, it will give the stimulus to the diaphragm and all the muscle of the inspiration and respiration. So the rate will be decided by the medulla. During heavy exercise, if the patient is if the child is healthy, in heavy exercise also the requirement increases. So the airflow increases 20-fold and blood flow increases 3-fold. To expel, remove such increased volume, passive exhalation will not only helpful. So we will require active exhalation even in a healthy individual. So in that, abdominal muscle and internal intercostal muscle will contract, and that is called a active aspiration. Now with this inspiration and expiration, there are some lung volumes according to the phase of your inspiration or expiration, and according to your how depth of your respiration, there are some lung volumes. So there are 4 standard lung volumes and 4 lung capacities, which is a combination in turn of the volumes also. By the spirometer, we can measure all these lung volume except the residual volume, because that air does not come out into the spirometer. So we cannot assess the residual volume. To assess the residual volume, there are another methods like xenon method and radioactive methods, which we cannot perform in the hospital. So everybody knows this. This is a spirometer. So this is a tidal volume, tidal respiration. This is at rest what we take inspiration and expiration. This is the forced inspiration and this is the forced expiration. And this is the residual volume. So with combination of all these, we will have the residual volume is the amount of air in the lung at the end of maximum exhalation. The maximum, so this is the volume which prevent the lung after full exhalation to remain patent. Tidal volume is the normal volume of air inhaled and exhaled with each normal breath, not exertion. Inspiratory reserve volume. You take a normal inspiration and then even you take forceful inspiration. So that volume is called inspiratory reserve volume. This is for the time of stress or exercise or disease when your requirement is high for the oxygen and removal of the thing. So that is called the inspiratory reserve volume. Same is the expiratory reserve volume, which we can expire with effort, with active expiration. Inspiratory capacity, same. What is the capacity of lung to inspiration? So it will combine the regular normal inspiration plus your inspiratory reserve volume. Functional residual capacity is the volume of air in the lung at the end of a normal exhalation. So after normal exhalation, how much air is remaining in your lung? That is called FRC. It is a very important volume of the lung, because in disease, it will, according to the type of the disease, it will increase or decrease, and that will affect our way of treating that disease. What is the vital capacity? It is a volume of air that can be exhaled after maximum inspiration. So how much air a lung can have in with normal inspiration, maximum inspiration and expiration, that is a vital capacity. And total lung capacity includes all the volumes. Changes in the lung volume are some of the earliest indicator of the lung disease. We do not perform this spirometry routinely, but if we do that and we can find out there are some the volumes like FRC, residual volume, total lung capacity, they are less or more than their normal value, then we can pick up this restrictive and obstructive disease earlier. So in obstructive disease, the amount of trapped air increases. The air which is remaining inside the lung after maximum expiration will increase. So the RV upon TLC will increase. In restrictive lung diseases, the lung cannot fill normally, even though RV TLC will increase, but here the TLC is reduced. The denominator is reduced. That's why it is increased. So we can these are the things which are hampered in very early stage of the disease. So we can also do this, but this residual volume we cannot do in a routine clinical practice. So it is also not of that importance. Now we will look after some physical properties of the lung, like elastic recoil, compliance, resistance, some surfactant property. All these properties of the lung, they intermingle with amongst themselves, and they will create an environment of the respiratory system for a patient to breathe normally or abnormally. So first is elastic recoil and a compliance. So lung is made up of a soft tissue, muscle, the airway, fluid. So all these things, they have elastic recoil. What is elastic recoil? If any stretchable tissue is there, at a normal, they have a normal resting state. If we stretch them, they will try to come back to that normal resting state. That is called an elastic recoil. So, and how much we can stretch them at up to which point, that is called compliance. So lung compliance is defined as a stretchability of the lung. So as we can stretch the lung with pressure. So what is the compliance for the lung? It is the change in the volume per change in the pressure. That is called the compliance of the lung. Greater the, so this is your lung volume, and this is the pressure difference of airway and the pleura. So greater the compliance, easier to expand the lung at any given time. So it is, and the compliance is inverse of the recoil. Compliance is the stretchability, and recoil is the as the tissue come into its normal position, stiffness. So compliance, as I told you, volume change per unit change in the pressure. Normal lung compliance is 200 ml per centimeter of H2O. So per 1 centimeter of H2O pressure will generate 200 ml of the volume. So that is a normal human lung compliance, adult. Reduced compliance in which diseases, like all the diseases in which fibrous tissue increases, alveolar edema happens, atelectasis happen, like in pneumonia, ARDS, or congested lung in cardiac conditions. So all these condition causes reducing compliance. And increase, there can be increased compliance also. Emphysema and increased aging, that will cause increase in the compliance. So their lung can inflate very fast with very low pressure. So to know relation between the pressure and volume, all the lung condition can be seen by this PV loop. This is the pressure volume loop. With how much change in pressure, how much volume is generating, that will give us the compliance. So this blue line is a normal compliance. In decreased compliance, like if we compare these two graphs, normal and decreased compliance graph, what can you say? You pick 2 points, like one here and one here. So from a pressure change from here to here, what can you say? See, like the volume will increase exponentially in a normal thing. From this much pressure difference, the volume is increasing very high. But in case of decreased compliance, with this much pressure difference, the volume is also not getting so much increase. So the lung stretchability is decreased. And similarly, with minimal pressure change, if the volume is so much increased, so there is a increased compliance. So in which type of this graph your patient's lung is, there, according to that, you can think that which kind of disease the patient is having. This decreased compliance is called restricted disease, and the increased compliance, that is not a disease, there is a normal thing. But in case of and another thing, what can you see? This is up to this mark there is a linear relationship, and after that in above part the curves flattens, because the slope of the pressure volume curve is at as we know, the pressure is, it is not a linear relationship. At high lung volume, the lungs which are almost maximally stretched, so after stretching the compliance decrease. So after a full maximum stretched lung, the same amount of pressure will cannot stretch the lung further, so there will not be a volume generation. So at a higher level, the lung compliance PV loop will flatten. Another property is a surface tension. What is surface tension? If we have smeared any surface with a fluid, those fluid particles, they have a intercurrent pressure to bring the particles to near themselves. So it is an attractive force between the fluid molecules. Pure water, in the surface tension is in of the pure water, it is very much great. So as our alveoli, it is lined with moisture, which is a pure water. So if there is no another mechanism, then the surface tension of the alveoli will be so high that it is very difficult to inflate them with our inspiratory effort. So to overcome this surface tension, the body has a substance which is lined in between this air fluid uh, barrier. So it is called a surfactant, which reduce the surface tension markedly and thereby increase the lung compliance. The lung surfactant is synthesized by the alveolar type 2 and secreted into the alveolar space by stretching the type 2 cells. So when the type 2 cells are in a resting stage, this surfactant will not secrete. But with, as we know, with first breath during the, after the birth, as the lungs stretch, with the stretching of this type 2 cell, there is a secretion of the surfactant. Major component of the surfactant is the phospholipid, which is inserted perpendicularly into the gas liquid interface, so that there are two ends, non-polar and polar. So non-polar hydrophobic fatty acid are pointed toward the gas, and polar end is toward the liquid. And by this mechanism, they will decrease the surface tension. The phospholipid forms a monolayer that generate the firm pressure opposing the surface tension. And one main thing, so when the alveoli collapse, the property of the surfactant increases and it will decrease the surface tension even more. So more the collapse of the alveoli, more decrease in the surface tension. More, why this is so much important that we will look. The surfactant stabilize the alveoli. Surface tension of the alveoli tends to pull inward, creating a pressure. So there is a one law, Laplace law. This law is for the uh, thing which don't have a substance like surfactant. Only to understand the surface tension, like in a balloon, there is a law called Laplace. So what will the pressure inside that balloon? It will depend upon the surface tension and the radius of that globe. So 2t upon r. So more is uh, the volume or the size of the balloon, the less will be the pressure inside that balloon, because surface tension is static. So if surface tension were, but if the same law, if it applies into the alveoli, what happen in our lung? The alveoli are not in the same size. Some alveoli are smaller, some are bigger. So if we apply this at Laplace law, according to the Laplace law, the larger alveoli will get less pressure inside them, and smaller will have a higher pressure inside them. So if in our lung there is no surfactant, what will happen? The pressure in the is one number of alveoli will be higher, and the pressure inside this two number will be low. So what will happen during steady state? This air from this smaller alveoli will go into the larger one, because here the pressure is low. But because of that, what will happen? These alveoli will get the already used air, not the fresh air from the air from the airway. Here the CO2 containing air, because the diffusion has already happened. So the CO2 containing air will go inside, and after these alveoli fully collapse, these alveoli will start emptying. So this is not helpful in a normal individual. But what happened with the surfactant? What I said told you, with the surfactant, the property of surfactant is more in a collapsed alveoli. So even though according to Laplace law, the pressure inside, surface tension inside this small alveoli is high, but to overcome this surface tension, the property of the surfactant also double. So there is the same pressure inside the number 1 and 2 alveoli with the help of surfactant. So the both alveoli will, with same pressure, will drain into the alveoli and will get the same fresh air with each inspiration. So this is in the normal thing, and this is in the pathological state in which the disease will lead to loss of surfactant. This is called a pendulum effect, because it is like the pendulum of the clock. The air will go inside and inside into the alveoli and not going outside, and all the used CO2 containing air is remaining inside the lung. So that is in a disease state. Now that was all the compliance. Now pressure changes, and another thing is a resistance. Why pressure changes? As we know, a flow of air or water or anything will happen only if there are difference in the pressure from one place to another. If the pressure are same at both point of a tube, then there will not be any flow of a fluid or a air. So to a flow of air to happen, there has to be a increase in the pressure in the lung, so that inspiration and expiration can happen. Now the lung and the mouth and the trachea, it is not a simple thing like a tube and a box in which there is a pressure of negative and positive and the air will go inside and outside very commonly. It is not such, because the lung itself is a covered with another cavity called pleura, and it is inside the chest cavity, and some part of the pleura is covering the airway, and some part of these all the airways, they are covered inside the pleura, and this is a extrapleural airway. So it is a complex thing. It is not such easy thing that the air is going inside and air is coming outside. So the chest wall, when the diaphragm and chest wall they expand, the diaphragm contracts, that pressure, it is not directly impinged on the alveoli. There is a sac in between, which is called pleural sac. So whatever the pressure change occur due to the expansion of the chest wall, that will first go into the pleura. That pressure difference will first go into the pleura. And as a pleura is a it have two layers. One, it is attached with our chest wall and diaphragm, which is a parietal, which is a external pleura, and another is our internal pleura, which has covered our airway and the lung. So when the chest wall expand, outer pleura expand, but due to the elastic recoil of the lung, there is a expanding force always in the pleura. So there is always a -2 to -8 negative mm of Hg negative pressure inside the pleura. It is maintained always negative. Even in the forced expiration, when the whole chest cavity is with a positive pressure, in that condition also the pleura has maintained your negative -2 to -8 mm of Hg negative pressure. So that is called pleural sac. Now, what determine the flow of airway from mouth to the alveoli? It is the transpulmonary pressure. The pressure difference between the alveolar pressure and the pleural pressure is the force that decide how much air will, not the full intrathoracic pressure, but the pressure difference between the alveoli and the pleural. So that is called a transpulmonary pressure. Now, as we know that pleural sac has always negative pressure, so the transpulmonary pressure will be always positive, because this minus this. So if at all the alveolar pressure is 0 and intrapleural pressure is -4, the transpulmonary pressure will be +4. So what this transpulmonary pressure will decide, it will make sure that your alveoli and your lung will always be inflated, because the transpulmonary pressure is always positive, +2 to +5, even in a, if the alveolar pressure is 0 at the end of the expiration, when no air movement is happening, at that time even in your alveoli, your pressure, transpulmonary pressure will be +2 to +5. So that's why your lung and your alveoli will not get collapsed. So transpulmonary pressure will always be positive and intrapleural pressure will always be negative. So when the inspiration occur, diaphragm chest wall movement occur, intrapleural pressure become more negative, transpulmonary pressure will become more positive, and it will expand your alveoli, and that will create a pressure gradient, and there is a movement of air. So as I said you, at the end of the exhalation, alveolar pressure is 0, intrapleural pressure is -5, transpulmonary pressure is +5. So it prevents the alveoli collapse. Now that is a pressure difference to make the air flow. But the flow of air also depend on two things. One is the difference of the pressure, and one is the resistance. How much resistance that air has to overcome, that also will decide how much volume of air will go into the lung. So an additional force that must be overcome during the normal breathing is the resistance. Measurement of this airway resistance is extremely useful and diagnostic tool because the change in the airway resistance accompany aging and many lung disease. So according to this resistant equation that R is equal to 8 nu L upon pi R square, the resistance will depend 8 nu L. Nu is the viscosity, L is the length of your airway, and the also depend on what is the type of the flow, turbulent or laminar, the compliance of the lung, the wall edema of the airway. All these things will decide how much the resistance is there. Now the flow of the air. There are two types of flow, laminar flow and turbulent flow. If the flow into the airway is laminar, the resistance is very low. But if it is a turbulent, then the resistance is high. We might think that in a larger airway, the flow is generally laminar, but that happen only into the trachea and major bronchi. After that, due to this branching, the laminar flow will become transitionally turbulent. But as the air go inside to the periphery of the lung, because of the so much of the branching, the total the surface area of that airways, it increased tremendously. So and the peripheral part of the lung, the airway again became laminar. Sorry, the airflow again became laminar. So in middle size airway, it is turbulent. In larger and in very small airway, it again become laminar. So there the resistance is very low. Why low and laminar flow is required into the periphery? Because when we take active inspiration, you all know the FEV1, the initial part of the inspiration, the flow is very high, and in later part of the inspiration, the flow is very low. So with low flow, the pressure is very low. So when the air reach to the terminal part of the respiratory tree, so that time the it will not have the same force to go into the airways. There is a very minimal pressure for the air to travel to the alveoli. So there has to be a very low resistance. So the system is such that in a lower, smaller airways, as the laminar flow, the flow become laminar, there is a very low resistance. So with even a low pressure, the air can easily go toward the alveoli. So that's why it is the system is such. So this thing apply only if the flow is laminar, because as we seen, the flow will depend on the viscosity, length, and the radius of the your airway or any tube. So uh, how the flow will what will decide that in a tube the flow will remain laminar or it will become turbulent? So that is called, it is a property of the system which include the pipe and the gas inside it. So both property combine and make a Reynolds number. If this Reynolds number is high, then the resistance is high. If it is low, near to 1, then the resistance is very low. So it is RVD. R is your radius. This is your viscosity density. And this is a your constant. So in a complicated system of a tube as a bronchial tree, it is a very complicated system. There are many branches, changes in a caliber, irregular wall surface. This thing cannot apply, because these will apply only into a single or two tube, which are very straight. So this is not uh, but so fully developed laminar flow only occurs in a very small airway, as I told you, where their Reynolds number, because all these airway, they will act as a normal tube. So there we can apply this Reynolds number, and there the Reynolds number is 1. So the resistance is very low. Now what factors will decide the resistance? So airway diameter. It is known that more narrow is the airway, the higher is the resistance, according to that resistance formula. But most of the resistance to the airflow, most of the resistance of the airflow is found in the mouth, trachea, and large alveoli. Now, the airway tree, initially it is a single tube, then it will divide into the 2 tube, then 3 and 2 tube. So in this larger airway, this principle will apply on into the larger airway only. Okay, when it contracts, the resistance increase; when it dilates, the resistance decrease. But what happened in our respiratory system in periphery, as I explained, there is less resistance because as airway divide and become narrower, they become more numerous. So the cut surface of airway, if you put them together, the surface, the opening is so large that the air can travel very easily. Small airways divide more rapidly than their diameter decrease. Therefore, the resistance of each individual airway is relatively high, but their total cross-sectional area is so great that their combined resistance is low, if you can understand this. So the airway diameter will not so much of importance in the peripheral part. Lung volume. Now the diameter of all airway lumen is also affected by lung volume. If the lung volume is very low, so what will happen? It will compress the airway. And if the lung volume is high, you have put enough tidal volume into the lung. So due to the elastic property of the lung, if there is an airway, there is in surrounding airway, there is a elastic lung tissue. So they are contractile. So they will pull the airway open. So they will keep the airway stented. Stenting will happen. So there must be an adequate lung volume all the time to keep the patent airway, the airway open. At high lung volume, the airway such as bronchi and bronchiole, they are pulled open and their resistance is lower. So in a way, a lung volume also decide your what will be your resistance. The same elastic recoil, it will also as I said, they will keep the airway open. So airway diameter will be affected by the transmural pressure. The transmural pressure is the same pressure difference, but it is inside the airway. That intraalveolar and intrapleural difference that we called as a transpulmonary pressure. But mural means the musculature of your tube. So inside the tube and outside the tube, there is a difference, different pressure during inspiration and expiration. So that difference from inside to outside, that is called transmural, which also should be always positive to keep your tube, your airway expanded, patent. So that in a tube, it is called transmural pressure. Although the airways are embedded into the soft tissue of the lung, the pressure that they are exposed to on their outside is close to the intrapleural pressure. The intrapleural negative pressure and the transpleural pressure that will also act onto your airway. So the transpleural pressure, which is exactly your transpleural pressure, for the tube or cavity is the difference of the pressure inside minus pressure outside. So if outside pressure is negative, then your transmural pressure is always positive and it will keep your airway pattern. So if by any disease, two things can happen. The elastic recoil of the lung can decrease, or your tube, the airway, they get constricted. So both these diseases, what they can do, they will decrease the difference between this pressure. They will decrease your transmural pressure. So from normal +5 +8, if it will become +2 +3, so what will happen? Your airway will become compressible. So let's look at this thing. If your airway become compressible and you have to do a force expiration in case of exercise or in case of your status asthmaticus, if you do a forceful expiration and your airway are not compliant, then what will happen, that we'll discuss. This is a pleural sac, and your it is a your extra pleural airway. This is your intrapleural airway. In the intrapleural airway, this is your cartilaginous airway and this is a non-cartilaginous airway. So this is a compressible airway. So there is a point which is called equal pressure point in our respiratory system, at which the intrapleural pressure and your airway pressure, they become equal. So in a normal person, that pressure point is inside the cartilaginous part of the airway. So, and after that, the pressure will decrease, because in expiration, the the alveolar pressure is high and oral pressure is low. Then only your flow of air will happen. So from 90, 80, 60s, 50, 20, 30, and 0. So there is a gradient, pressure gradient. So there comes one point where your, because of the force expiration, your pressure inside your this lung, it is positive. So this, if imagine this equal pressure point come into this part of the lung, like in this diseased person, where like in emphysema or in case of bronchospasm, because of this pressure point, it come into the your compressible part of the airway. So what will happen? Beyond that point, when the pressure falls, because of this positive intrapleural pressure and less pressure inside the airway, your intramural transmural pressure will become negative. 50 minus 60, it will give -10. So that time your tube collapses. So during forceful expiration in an obstructed disease, when the bucket handling is happening, child is using the abdominal muscle and accessory muscle and try to force out the air, what will happen? There will be a dynamic compression of your peripheral airways. This is called dynamic compression. So what will happen? Say 100 ml of air come into your lung, and at the end of expiration, all that 100 ml cannot go out. So with each expiration, because of this dynamic compression, some amount of that 100 ml, each time 10 ml of that air is remaining inside your lung, and your lung will expand. So there is a, in X-ray of obstructive lung disease, we see expanded lung, because the same amount of air cannot go out because of this dynamic compression of the airway. So it is also called a waterfall effect, Starling resistance, or slush. So again, we can see during just the expiration stop, just before inspiration, there is the equilibrium. The alveoli and the mouth, there is a 0, 0, 0 pressure, and the transpleural pressure is +5 because the intrapleural pressure is -5. When the diaphragm contracts, there is a -2 mm of Hg, more negative. So intrapleural become -7, intraalveolar become -2. So from 0 to -2, there is a flow. Now at the end of expiration, there again it become 0 0 0. But as the we have the lung is contracted, still the your air intramural pressure is still positive, so the airway is not collapsed. But if you do a forced expiration, you say you have applied a plus 30 mm of Hg of uh, force. So if your airway is collapsible or obstructive lung disease is there, which decrease in pressure gradient in in this part, there is a minus negative transmural pressure, so your airway will collapse. So why we are discussing this so much, this will explain later on that if we have to give oxygen support or intubate a patient with a collapsed airway or obstructive airway, we have to give some positive pressure to overcome this minus 11, which is just an example, to positive. So if we give here, if I give 11 pip, then the difference will be 0. So my airway will be patent. Okay. This is just an example. So by knowing all this physiology, I can know that why in case already in the statistics. So why? So the resistance, as we see, it will depend on the airway diameter, on the lung volume, on the this elastic recoil, and the muscle tone of the airway is also important, because as we know, the in asthma, that smooth muscle got relaxed. So if there is a less muscle tone, then also your muscle this airway get collapsed. Parasympathetic stimulation called construction of the bronchial muscle. So there could be a bronchospasm also. So that four factors decide the resistance. So we looked about the compliance, the surfactant, the resistance, the elastic recoil. So all these factors, they act with each other, and they make a environment in our respiratory system. So everything is dependent on each other. Another thing also act on our lung is the gravity. Our lung in our thoracic cage, they are hanging from, there are two airbags hanging with the mediastinum. So the in upright position, gravity also pull down the lung. So there is a difference between the size of the alveoli above in above part and in the lower part. This part is hanging, so the stretching of the alveoli is more into the upper part, and this lower part, it is resting on the diaphragm. So here the pulling in the on the alveoli is not such. So in the upper part, the intrapleural pressure are more negative due to the stretching, due to gravity. So there is a greater transpleural pressure. So alveoli are larger, but the larger alveoli are less compliant. If alveoli can distend this much, the upper part has already distended, so they cannot expand more. So the ventilation in and out of the air, it is not happening much into the upper part. Also due to the gravity, this we will go in later part, but the blood supply is also less, because all due to gravity, all the blood will come into the basal part. So here the ventilation is also less and the perfusion is also less. But as we come gradually down to the lower part of the lung, where there is less negative intrapleural pressure because the lung is resting. So the transpleural pressure gradient is low. So here the alveoli has capacity still to extend. So if I give a positive pressure ventilation, my ventilation will happen more in the dependent part because those alveoli are still collapsed. So I can expand them more. So my ventilation will more, and the blood supply here is also more. So the diffusion, the gas exchange will happen more in this. But as we are patients, the the length is more, the width of the lung is less. So that much as in upright position. Even though so my ventilation and perfusion, they will happening in the dependent part also. So why we are discussing it? This will decide that if in which position we should ventilate our patients. If the patient is having your pneumonia or your collapse more into the posterior part of your lung, if you make them prone, so what will happen? Due to gravity, those collapsed alveoli will open and my air will go into the upper part, which is in supine position, which were more collapsed. Why I have to prone? Because if I increase the ventilation on upper part, as the upper part has more blood vessels and more blood, my ventilation and perfusion mismatch will decrease. This is a bit more for the basic physiology part, but this is why we are looking for this physiology part so that we can understand the disease part better. So this is the first part of the talk. In this part, we just know that how the atmospheric air with overcoming all the physiological interaction came into the alveoli. Now in another part, we will look that how a gas in the alveoli go into your blood and then go into the uh, to your tissue. So that will be the next part. So thank you.
Thank you, Jignesh. Thank you very much.
Jignesh, yeah.
Yes, sir.
Uh, Jignesh, you have very well covered this. This is a very complex